This episode of The Next Breast Thing was made possible through the generous support of Myriad Oncology.
Myriad Oncology provides a portfolio of advanced genetic and tumor genomic testing solutions, including risk assessment, screening, tools to aid treatment guidance, and survivorship planning. The Myriad Oncology offering is designed to meet the unique needs of oncology specialists and their patients across each step in the patient care continuum.
To learn more, visit myriad.com/oncology.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
Dealing with side effects of breast cancer treatment.
unofficial end of summer, and with that brings football. I went to this kind of mini NBA, M as in mouse. It's called Business Mastery with Tony
I
Robbins.
don't want to make a big deal out of this, but I almost died this weekend.
We had a back to school party for some of the students at the University of Colorado, and over 100 people came to
So
our house.
I've always wanted to go fly fishing and went fly fishing this weekend. How do we talk about side effects from chemotherapy, radiation, endocrine treatment?
As a new surgeon, I don't always think about those things. I'm not the radiation expert. It's unfortunately absolutely impossible to discuss all of
What practical tips do you give your patients to get through the side effects?
I will tell you the one that I get asked about the most for side effects is,
What I try to do is familiarize myself with kind of the major.
it's a little risky, but one of the things I also do is say, what are you?
The number one thing, if I'm telling someone that they need chemotherapy that they're afraid of, is
This is Carla, Ellie,
Michael.
Susie.
and Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community,
We're a group of devoted surgeons from different parts of the country.
inviting you to journey with us into the science of breast.
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.
Today, our topic is dealing with side effects of breast cancer treatment. But before we get started, let's begin with some personal and professional updates as usual. Carla, let's begin with you. What's new?
Well, as we all know, it is the unofficial end of summer, and with that brings football. So I hope everybody is looking forward to the Philadelphia Eagles
Oh, here we-
football.
There
Yep.
we go.
Yep. So I'm glad you're on board, Michael. As you all are probably well prepared, the Philadelphia Eagles will be kicking off the season with a Thursday night game against the Dallas Cowboys. So
There you go.
I'm looking forward to that. Very excited. I'm a summer girl and always sad to see the summer end, but fall and great weather and football makes it a little bit easier to transition.
By the time this airs, we'll know the result.
I think we all know what the result is going to be. Ellie, how about you?
Very happy for you, Carla. I am not a football fan, but happy that that lights you up.
Ellie, just by looking at your face, I already knew that you were not a football fan. You sort of glazed over as Carla started speaking.
Yeah. Well, I grew up in the Midwest. Football and basketball was life, and very much against my will. Now that I live away from it, I get a nice break. But again, I'm happy for you guys that you like it. I recently got back from Florida, actually. Very hot. Very much would advise against traveling there in the summer. However, I had a great time. I went to this kind of mini NBA, M as in mouse. It's called Business Mastery with Tony Robbins. It was like a 6-day pretty intensive event. met a lot of people trying to learn about business or building businesses. Carla, I know you have your MBA, and I can't imagine that it was similar to whatever you had, which was like a 2-year experience. But it was just great to learn about a lot of stuff that we never get taught in medicine and just kind of take it back to my surgical practice and implement those tools. So, Michael, what about you? What's new with you?
I don't want to make a big deal out of this, but I almost died this weekend. It is football season, Carla, except it's college football season, so I loaded up the RV and went to the college kickoff, and at 1:30, they're pounding on the door of my RV saying my RV is on fire. Ran out in my skivvies, met the firemen out there. A lot of fun. My hot water heater caught on fire. So,
Goodness.
I know you're lucky I'm still here. I battled it like I battled the snake. But I'm still alive. And then I didn't really have anywhere to sleep that night. So I just basically parked up in a truck stop and listened to the Next Breast Thing podcast.
Part of the breast community and can't seem to find the answers? This is the Next Breast Thing.
One after the other for 4 hours. So I'm tired of you people already. That was my football weekend, and we lost. So it just went really well. So
Went up in flames.
that's how it is. Susie, you could take this RV with you to the Outback or wherever your next hammock-laden venture is. It's a little smoky, but I think it adds to
I
the...
think she goes a little more off the beat than that.
not
I'm not gonna lie. I've always wanted to do an RV trip, and I just haven't done it yet. But we had a back to school party for some of the students at the University of Colorado. And it was just a way for them to meet outside of a Greek system. Not that that's bad or anything. And over 100 people came to our house, and they had vans picking them up on campus, driving to my house in the neighborhood. And I was like, oh my goodness. And my husband and I, we did all the cooking. It was super fun. And these kids were so polite, great. And it was a really fun time. No alcohol. No, they had fizzy water. I had to also break out some cups to get some non-fizzy water. But we have this commercial smoker, and we had pork butts, and we had brisket, and we had chicken, and it was great. I made like 260 cookies from scratch, and it was just fun. We had a great time.
Susie's updates are always the best. I think we always have to save them for last because they just are amazing.
So what's the connection? Did you go there?
No, I went to Davidson College, but we live here. Oh my God.
Yeah.
Okay, Susan.
So I've always wanted to go fly fishing and went fly fishing this weekend, and I loved it. I don't know if any of you have ever done it.
Yeah.
It's super cool, fun, and very different than regular fishing.
Did you have a guide?
Yes. So for anyone who's listening that lives in the Northeast, and I'm not getting paid for this, and I'm probably going to irritate my co-host, but there's this place in Woodstock, Vermont called the Woodstock Inn. It is a fabulous weekend or a few days. So cool. They have everything there. It's one of these places you can park your car when you get there, and you don't need to get in the car the whole time. It's about 500 feet from town, so you walk to the restaurants, but they have tennis and pickleball and an incredible gym and golf, and then you can go fly fishing, and everywhere you look is a hiking trail. It was just super cool. Highly recommend it. And fly fishing, I will be doing that again.
And this episode of the Next Breast Thing podcast is brought to you by the Woodstock Inn.
Just gonna say, in other news, we are taking sponsorships.
Yeah.
It is. You see, you thought our sponsorships were about breast something, but here's the Woodstock Inn. But highly, highly recommend it. Now that I've given a sponsorship away to the Woodstock Inn, let's move on to our topic. As breast surgeons, Some days we're walking in front, some days we're walking behind, but we're always right there with our patients through every phase of their treatment. Not just the surgery, and that's why we're sort of the quarterback of the team. So how do we talk about side effects from chemotherapy, radiation, endocrine treatment, targeted treatments? We know these treatment side effects can be debilitating, and they directly impact quality of life and outcomes. The question really is, how can we best help our patients when it comes to dealing with these side effects? Do you talk to your patients about the expected side effects? So much is setting expectations. So we know we talk to them about surgery, we get informed consent, we talk about the potential complications from surgery, but do we really discuss the complications from all the other treatment recommendations that we're giving them?
I try to tell them what I can. I definitely say to them, look, your chemo regimen is going to be decided upon by another team member, or radiation. We'll go through kind of some of the general side effects for that. But again, I do preface it that I am not the specialist performing that. So these are general understandings that I have. And these are kind of the most well-known side effects. Now, can I give you the individual treatment plan that they're going to do for you? No. Can I tell you exactly what they're going to prescribe? No. But I can prime them. We know that priming people for things works way better than surprising them afterwards and being like, oh, by the way, radiation, you might get a rash, or you might get skin thickening, or this might put that implant at risk that you're getting. I think it's very important to talk them through what might be coming. As a new surgeon, I don't always think about those things, and me talking through their process helps me check all the boxes and think about the full picture of what they're going to be going through for the next however many months. But at the same time, I do recognize that I'm not the radiation expert or the chemotherapy expert, and I rely on my team members that are going to see them to fully give them the informed consent. I don't expect the medical oncologist to give them informed consent for surgery and vice versa. So that's at least in my early practice how I've handled it.
There's a lot to say here. One of the things that comes up often in our conversations is all of the different things we have to talk to patients about as surgeons. And I think covering side effects would add hours of conversations to our conversations with patients. The way I look at it is as surgeons and quarterbacks, which I like the football reference, kind of sticking with that theme. Thank you.
I did that for you.
We should be prepared to discuss all of those things with our patients. Now, I can't go through a laundry list of side effects of endocrine therapy per se, but can I touch on that and certainly speak to that? Absolutely. Same thing with radiation. And I think I can probably speak a little bit more directly to radiation because implications of doing or not doing radiation maybe more directly affect me as a surgeon. I also think it's unfortunately absolutely impossible to discuss all of the potential side effects that a patient can have. And so trying to pick and choose what you're going to discuss with a patient can be a little bit difficult. It might be interesting to hear what things we sort of touch on with our different patients. I will tell you the one that I get asked about the most for side effects is endocrine therapy. When I talk to patients about the range of different things that patients might be exposed to or be asked to do, endocrine therapy is the big one that comes up. And while I can touch on that, I think it's a really nuanced discussion. I also worry sometimes when we discuss some of the side effects, how much we are priming patients to kind of think about and worry about some of those things. And I think there is that fine line of you want patients to hear it a couple times, but at the same time, I think if you list 50 things that might happen with endocrine therapy, I mean, we all know it's a challenge to get patients on that already.
In asking this question, it's really almost the 20,000 foot view. So Susie, you have a patient who comes in with a 2.5 centimeter node positive, triple negative breast cancer. You know, sitting there, that they should get neoadjuvant chemotherapy. You also know that they're going to lose their hair. Do you discuss that?
Yeah, absolutely. I mean, this is tough, and it is not my job to hide something that's hard from a patient. This isn't my disease. This is theirs, and chemotherapy will be recommended. It does not mean they're going to do it, but this is a hard deal, and it is hard to lose your hair, and that can be a lot with image. And for some people, it's not. But it is very important to discuss, hey, this is the deal that you see. This is chemotherapy that causes your hair to fall out. Not all chemotherapies cause that. And likewise, I get questions about, is radiation the thing that makes my hair fall out? And being able to confidently be like, nope, that's not what that is. We have 3 pillars to help treat you, and we need to give you the percentage of where we think this is going to help you. Most times, we're really on it. But sometimes, even going through a therapy, it can hurt you too. And it's really important to be able to have that discussion with patients and be real about that. Or if neuropathy is part of it, or cracking fingernails, what are some of the things that they can expect?
So, Michael, as surgeons, we are typically the first stop. As Susie just said, patients going for chemotherapy that she knows side effect is hair loss, she absolutely will bring that up. Now, that's a short-term side effect. Are you more likely to discuss short-term side effects at that visit? Or are you going into, you could get neuropathy? Are you going into long-term side effects also? And is there a right or wrong to how to approach this?
What I try to do is familiarize myself with kind of the major ones. If they ask you a question, I've never seen that before, because that creates a whole nother set of problems. But familiarize myself with the major side effects. If they're going to lose their hair, I'm going to tell them, here's how we're going to try to handle that. We can cold cap. I can write you a prescription for a cranial prosthesis or wig, and we can sort of address that on the front end. So we've talked about it.
Cranial prosthesis.
That's what you've got to write the prescription for. I know.
How many people refer to a wig as a cranial prosthesis?
The insurance companies for...
How about
Not me.
Well, no, I don't say it to the patient, but I'm saying when I'm writing a prescription, it's a cranial prosthesis.
I'm not sure I've heard that term.
Make the rules up. I just follow. But, if somebody's on a taxane, I'm looking at their nail beds. I'm asking them about neuropathy and just checking in on them. They want to know that you know what they're going through and that these are common side effects, that what they're experiencing that they may or may not bring up is normal and common. And if there are things that pop up that are out of the abnormal, then we call and we talk to the medical oncologist and say, this is what we're seeing, and this isn't in the normal checklist of things that I encounter.
It's a little risky, but one of the things I also do is say, what are you most afraid of? People are smart. It's not like people don't understand what chemotherapy does to you, maybe not specific chemo regimens, but it's interesting hearing what they are most afraid of, whether it's accurate or not accurate for the type that they may have, and why are they afraid of that? Is it a body image thing, or is it that their body may not recover to gain back to their athletic strength, or is it about infertility, a permanent thing? And I think that really helps frame that discussion.
I think the number one thing, if I'm telling someone that they need chemotherapy, that they're afraid of, is dying. Am I going to die from this disease? And if they don't bring it up, I do, because they're thinking it. There's very few people, especially with, say, a node-positive cancer, that the thought of dying does not go through their head. So they're afraid to say it. They're with their spouse, they're with their best friend, they're with one of their parents or children. They don't want to bring it up, not just because they're not thinking of it. They don't want to bring it up to say it in front of their loved one. So I do think that it is up to us to bring that up, because they're thinking of it and they're just afraid to say it. They're worried about dying. Am I going to see my kids graduate college? Am I going to see them get married? And that's the questions I get.
I think it's important. What's important to the person? Is it their vacation to Africa? Is it seeing a baby being born? Is it how they appear because they're a public figure? I think it's important to really see where people are coming from and what they are most afraid of.
It is the elephant in the room that you can die from this. And I think addressing it is important. Now, it is interesting. I will tell a patient, you're going to have surgery, you're going to have chemotherapy, you're going to have radiation. And then when I do say you're going to lose your hair, that's when the tears seem to start.
Oh, absolutely.
And so it clearly is an issue for them. And I guess they feel like they can do the other stuff internally. And then that is more of a visible evidence of sickness. But that's where the tears usually start, that I have found, is not that you're going to have chemotherapy, but you're going to lose your hair. And all of a sudden that seems to be where the floodgates open up.
I'm more concerned when someone's not upset. Like, it's fine.
Right.
It's fine. Everything's fine. None of it is fine. You have cancer. None of it is fine. Carla?
One of the things I wanted to point out, because Michael brought up chemotherapy and specifically taxanes, and we're talking about side effects, that's important to point out. Research that's been done looking at differing side effects in different patients, and specifically African American patients. We've really seen genetic differences in how drugs affect patients differently. And I think with chemotherapy, that's really interesting because we know that our African American patients die from breast cancers, don't do as well. And we've looked at multiple different reasons why that is. One of the reasons is some of the side effects that they get from these taxanes are worse. The doses based on that get reduced. Therefore, they get less of this life-saving chemotherapy drug because of that. And so I think the research that's really looking at how different chemotherapy drugs affect patients differently is really important for our different patient populations. And knowing that all of these drugs affect our patients, not just from patient A to patient B, but our different groups of patients, is helpful and I think important to surgeons and physicians to understand in talking to patients.
So, Ellie, what practical tips do you give your patients to get through the side effects, whatever they may be?
The first thing I talk to them about is community connections, support groups. We're actually organizing a monthly cancer patient walk at my hospital so that they can get together and just talk to other people going through this. The chat rooms is also a lot of the places that they go. Just trying to have a place where they can have community around them to say like, hey, what cream works for your fingernails? Those things, we can never give them that as the surgeon in that specific appointment. So having that support system for them is, at least what I've found, to be the most effective thing to help them with the side effects. Because yeah, I can tell them about it, but having friends that are going through the same thing that can give them little tips and tricks, I think that makes a world of difference. And it also makes it a better experience for them to have someone on their journey. And this all starts when they're talking to each other in the waiting room. They do it naturally. So why not help guide them?
Susie?
I think the most important thing is giving the patients freedom to speak up and say what's going on. Like, I got this sore in my mouth. And being able to go, oh, did you bite your cheek? Oh, that might be from that. Or is it from something else? Whatever it is, if they forget, because it is such an amazing amount of information, even in a chemo teach class. And for surgeons out there who've never gone to one of those, I encourage you to go see what that's like for the patient and all that information that gets crammed in to understand. Because you walk out of there and you're like, wow, that's a lot. So if you haven't done that or don't have experience, I think that's a really interesting thing. Or being a guest at a support group really helps you understand the vibe of that community. And it's really neat for people that they don't have to rely always on a family member and feel like they're unloading on them, but they have somebody else in their community at different stages that can help them, and taking advantage of services through integrative care.
Mm-hmm. Yeah.
Michael, what about you?
The practical tips, I think, are to anticipate a little bit of what's going on and just sort of prepare them for that. I'm going to shift a little bit. Carla had brought up endocrine therapy. And when you want to start talking about side effects, because when you're getting chemo, you're getting an infusion, you expect it to be bad, it's going to start, and maybe in 4 months it's going to be over, and I can deal with this for 4 months. But you start putting people on endocrine therapy and you're looking at 5 years, 10 years, and it's a pill. So it's just this little thing that I take. Surely it's not going to be as serious as it is. And those side effects really affect even people using these medications. They just say, look, it can't be this important for me to do it, and I've got to take it for 5 years. So that to me is a harder side effect to deal with, in the people having tremendous hot flashes and say, well, just tough this out for another 5, 6 years. We've got to do better with those. I'd love to hear from you guys as to what you have done from side effects from an endocrine therapy standpoint, because you're in it for the duration for these medications a lot of times. So how do we deal with that?
I'll be honest, I'm not the person having a conversation with the patient about those side effects. That's going to be my medical oncologist. But for the patients that I am seeing who are on those medications, kind of going back to what Susie said, I think giving the patient the opportunity to stop the medication if it really is detrimental to their quality of life. Some patients have low rates of risks of recurrence and some patients are in a different situation. So trying to negotiate that with them. I might have some patients who had a T1A, N0 or NX tumor, and while the medication can be helpful and also is a risk reducing agent, do they have to take it? That's a different conversation. And other patients might be young with a T2, N1 ER positive tumor and truly will benefit from that medication. So how we can navigate them through that is helpful. There's no one size fits all model. I talk about this a lot, but diet and exercise is a huge part of our lives. Exercise needs to be more prescriptive. One of the things I will say in terms of my practical advice, when a patient's first diagnosed, people often want to kind of go vegan or sort of change their diet dramatically. And I think go out and eat the ice cream, go out and have the glass of wine if that's what makes you happy. Do what you need to do, but transition to that good quality of what you're putting in your body, because that's just as important as that pill that you're taking. Those are tough things to kind of transition to over time, but you do have to do the work besides the pills and the other things. And those things are harder to do, but you have time to do those when you're taking a pill over many, many years.
With endocrine therapy, they are often told there's a 50% reduction. And I say, go back and say 50% from what? Is that 4% to 2%? Because you need to know that absolute risk for the patient. And then I generally say a third of people, it's like taking a vitamin. It's hard to take because you got to put it in a pill box to remember to take every day. And a third of people can be really, really terrible side effects. And if the side effects are so bad you don't want to get out of bed, that's not the right medicine. But again, speak up and see if there's something else we can do instead. And if that's not right, we know we tried. We can't always fix everything, and you don't want to necessarily prescribe 3 other medications to mitigate some side effects, and just doesn't work that way. And a third of people do have side effects long-term, but manageable, and where they're still able to have that quality of life. And I think really having that open discussion of, you can come here and say, this is going on, and help us understand where those symptoms are for you. Because you're right, it affects patients in different ways.
And I do think it's one of those medications where if it doesn't work, you stop it. We know that there are very serious, rare side effects of endocrine therapy that obviously don't happen that often. But many of the side effects we're referring to, when you stop the medication, the side effects stop. The discussion that I have often with patients is, try it. You may not have all those side effects that you've read about, and you're benefiting from it. And then if you have those side effects and you stop the medication, I've found those side effects will stop. It's not like chemotherapy where once you've crossed that line, you've had chemotherapy and your body is changed because of that.
Yeah, we'll put them on a few-week drug holiday because they'll come in on an AI and their joints are hurting. Say, okay, maybe it's your arthritis, but maybe it's the endocrine treatment. So let's take a few weeks off. If it goes away, it's the endocrine treatment. If it doesn't go away, it's you, unfortunately, and then let's deal with that. But they're very willing to go back on the medication if it did not go away. It's an interesting phenomenon because they now believe it's not due to that. But I'm always shocked at how quickly these discussions go by. I'm not sure, as Michael says to me, that we ever answer any questions. We just seem to come up with a lot of them. But let's go around and get a takeaway. Michael, what's your takeaway tonight?
I think a takeaway is just being aware that the side effects exist and to look out for them and just talk with the patient about what they are, what they can expect, and let them know that what they're experiencing is kind of expected given certain medications. And then just to be on the lookout for things that are a little bit outside of the norm, just making yourself aware of the major side effects of what we're giving to our patients.
Susie?
I think a good takeaway is that patients should have the opportunity to speak up, and that we will be honest with our answers and forthright, whether that be about mortality or possible side effects or what we can hope to do to mitigate those symptoms.
Ellie?
My big takeaway here is kind of along the lines of what Susie's saying, is giving them space. So many times the patients just want permission to say like, hey, this medication is horrible. Is it okay if I stop it? And just giving them the space to say that out loud. And you talk them through other options like Carla's talking about with the diet, making sure that everything else in your life is tied up in a bow. We have to think about their quality of life.
Carla, you get to wrap it up with a takeaway.
Side effects for one patient might be different than how side effects affect another patient. And having that discussion with your patient and helping them understand where their priorities are and how a drug or a treatment might affect them differently and honoring their decision.
Basically, treat our patients like we would like to be treated. Someone hears us, listens to us, and we make decisions together. So, to all of our listeners throughout the entire breast community, we're so excited you've joined us on this journey once again. We'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.